And Crystal asks, can you explain the web interface for quality reporting? We are a part of an ACO that has many different EMRs, and we are unable to submit an ECQM QRDA.
Crystal, great question. Uh, Perhaps a little more complex in the answer than you may have been hoping for. Let me first explain the CMS web interface and then your options to move away from that. First, the CMS web interface has been an option for quality reporting since about 2013. It's been a requirement for the Medicare Shared Savings Program ACOs to meet their quality reporting obligations, and it's been an option for group practices with 25 or more providers to meet their MIPS quality reporting obligations. In the current model of the web interface, Medicare delivers to each participating practice or entity at the close of each performance year a list of attributed patients eligible for each of the 10 measures of the web interface. The entity is required to report performance against the measure on the first 248 patients on each measure's patient list. 248 patients for each measure multiplied by 10 measures equals 2,480 chart abstractions to complete each episode of quality performance analysis. It seems a daunting task until you realize first, many of the measures group together so that a single chart abstraction serves multiple measures. And second, when your provider group is more than 25 providers, as it pretty much has to be to use the web interface, it averages out to less than 10 patient charts per provider per measure, which is really quite doable in healthcare systems that may be caring for hundreds of thousands of patients. The annual process compares favorably in effort and costs to the electronic processes required to tame the data chaos that exists in most healthcare communities. If your goal is a simple annual estimation of quality performance on a statistically significant sampling of patients, you would continue to use a web interface, chart abstraction process, or something like it. But annual chart abstraction is a dead end that doesn't lead to many other great things that should come from your quality measurement system. The data and processes behind annual quality measurement and reporting have many other potential uses that are desirable in a system of high value care. Performed repeatedly, it's the foundation for a quality improvement system. Annual measurement is just too infrequent to drive quality improvement. You need at least quarterly, if not monthly or weekly measurements to power any credible quality improvement process. It's also the same data you need for analyses of gaps in care. Your quality assessment system should ultimately be usable at the time and place of care as a decision support tool. The same data, the same process, refreshed at least weekly, if not daily, or at the moment of care. The value of care is not restricted to our Medicare patients, to which a web interface is limited, but it's applicable to all patients of all payers. And finally, ultimately, when we have mastered the infrastructure, overall quality of our care is not dependent merely on the care of diabetes, hypertension, and depression, as implied by the APP measure requirements, but by our success distributing tens of thousands of evidence based rules that are found by close scrutiny of healthcare literature. For these and other reasons, Medicare has decided to sunset the web interface quality assessment system in favor of measuring quality of care across all patients and all payers. The current expectation is that you can still use the web interface to assess the quality of your care in your ACO for the 2023 and 2024 performance years. After that, you'll need to use ECQMs or MIPS CQMs to measure the quality of care in your ACO for all patients of all payers. Getting back to your core question, where you imply that you have two choices: ECQMs that won't work for the reasons we're all intimately familiar with, and the web interface that's expected to sunset after the 2024 performance year. Let's face it, ECQMs are just not ready for prime time. In the long run, I think there's far too much to the technical side as web interfaces to the manual side. I don't think they're ever going to be suitable for a robust system of measurement. I think the only affordable, scalable, and sustainable systems will be built on MIPS CQMs. Here at Mingle, we have been making MIPS CQMs work in complex environments and successfully and affordably normalizing data and matching patients across disparate electronic health records and practice management systems for over a decade. You should engage us and put us to the test for your 2023 performance year. You owe it to yourself and to your patients to prove that we can solve this problem for you before you waste 2 more years on the web interface or blow your budget on an unsustainable ECQM infrastructure.